Good morning, everyone. And my topic today is on the treatment adherence in psoriasis. Dr. Gashanja has already talked about psoriasis. So I'll just talk about what factors are involved in the adherence of treatment in psoriasis. So as we've heard, it is a chronic immune-mediated inflammatory condition. And most patients are usually diagnosed before the age of 30. Thus, they will use the medications for most of their adult life. And most of the patients experience a lot of dissatisfaction with the medication, maybe mainly due to the lack of formal support and also experience adherence difficulties. Yet there are very few high quality studies that have been done to study the adherence of therapies used in psoriasis. So the adherence rates in psoriasis are suboptimal, which highlights the need to improve patient compliance and satisfaction with treatment. We usually don't take into account the patient's preferences, which I think we need to do when we are making the decision of treatment. So what is the term medical adherence? So it refers to the extent to which medication corresponds with agreed recommendations from a healthcare provider. So in non-adherence is the opposite of that. So the patient not doing the recommendations according to the healthcare provider. So there are two types of non-adherence, intentional and unintentional. So the intentional non-adherence is where it is deliberate and largely associated with the patient motivation. And the unintentional is whereby the patient lacks the capacity or resources to take the medication. So this is just a diagram to show what I've just said. So we see the unintentional non-adherence is whereby the patient doesn't have the ability or the resources. So it's practical patient barriers to adherence. And the intentional is according to the patient's beliefs and motivation, so the patient's perception. So the predictive factors of adherence in taking the medication, we have classified them into 4: patient-related, treatment-related, disease-related, and physician-related. So for the patient-related factors, there are psychological factors. So for patients with increased psychological distress and low patient satisfaction with care or therapy were associated with lower levels of adherence. That means the patients who are not satisfied or had other psychological issues with their medication will not adhere to the medication more. There are also the patient beliefs about their diseases and medications. Most patients don't understand the disease or the treatment modality that you're giving them. They also have treatment concerns and they're not aware of the necessity of the treatment. Another patient-related factor is the lifestyle of the patient. So it was noted that patients who drink alcohol at whatever age were reported to miss doses of treatment, and also heavy smokers were less adherent. There's also the physical barriers. If, for example, the distance from their house to the clinic is farther, the patients were less adherent, and also physically challenged patients because of lack of the facilities were also less adherent. So the age, gender, and marital status, older patients were found to be more adherent, and women who are married and employed had an increased adherence. However, it was also noted that single or divorced patients were more adherent than the married patients, mainly because physical appearance is more important in single people. The socioeconomic status. So educated patients were more aware about their disease and had more knowledge about psoriasis. Employed versus employed patients. So the employed patients took time to take care of themselves and their treatment because, they have to look good at work. The medication cost, cash patients versus health insurance patients. So patients who are mainly paying cash usually have less adherence because if the cash is not coming in, they will not be able to afford the medication. Social support. So some families do not support the patients on the treatment of the psoriasis. They assume it's just something that can be taken care of if you just hide it. So if the patient won't have the support, they may not be adherent to the medication. And the main thing, people forget to take medication. So forgetfulness. So that is also a patient-related factor. So a treatment-related factor is the treatment vehicle. So patients who are less adherent to the topical medications, mainly because of the cosmetic acceptability. So they're either too greasy or smelly. For the patients taking oral agents, they will always complain about upset stomachs. So they were less adherent to the medication. The medication efficacy expectations from the patients. Patients are reported to be more adherent with biologic agents, mainly because of the efficacy involved. And also patients are more adherent if the time free from symptoms is longer. So if you give a patient a medication that will allow them to be free of symptoms for longer, they will be more adherent. Time consumption. So the patient's frequency of therapy administrations. So for oral medication, usually it is daily. Intravenous, it is usually monthly. And subcutaneous, it is usually quarterly. So patients would actually prefer the time that it would take them less to use the medication. So the subcutaneous or the intravenous route versus the oral medication. Also, consideration is time to improvement. Will the medication take 1 month, 3 months, or 6 months? Complexity in medication administration. So different topical agents. Okay, so for most patients with psoriasis, the medication may be applied on the face is different from the one applied on the rest of the body. The timings, all that. So now patients find it complex to understand that this is for the face, this is for the body, this is for the morning, this is for the evening. So if it is that complex, the patient will just give up and not adhere to the medication. Interference with the patient's lifestyle. So some patients who are put on methotrexate and take alcohol may not be adherent because one, they don't want to stop taking the alcohol or they don't want to reduce the amount of alcohol they usually take. Some patients are actually say they are too busy for the treatment modality prescribed. For example, if you tell a patient to take oral medication 2 times a day, they may not adhere or forget or say they forgot in the morning or they were too busy hurrying to go to work. Tolerability of the symptoms, of the side effects. Some patients are not able to tolerate, for example, if it is an upset stomach, if it is the cosmetic acceptability of the topical medication. So they may be less adherent in that aspect. The financial burden. So cost of the medication. Some of these medications, when we're prescribing, we need to know the cost to the patient and how many doctor's visits these patients are going to have so that we know if the patient will be able to afford either the first medication or the follow-up after the medication. So the disease-related factors. So one is the location of the lesions. A patient with a lesion on the face will be more adherent because that is the first thing that you see when you speak to anyone. Also the severity. It will also determine which agent to use. So systemic or biologic agents are used in severe disease. Then this has a higher efficacy, so the patient will be more adherent to the medication. So chronicity, it was found that more chronic patients are less adherent because they have already learned to live with the disease. So they don't see the need of using the medication because it hasn't worked in previous times. Also, that together ties in together with the involved body surface area. It has been shown also that patients with increased body surface area are usually less adherent, maybe because they've already gotten used to the disease, or they find that the medication is not helping and it is still spreading. So they don't see the need of them continuing with the medication. So we come to us as physicians or as dermatologists. So what are the factors that are causing the patient not to be adherent according to us? So frequency of follow-up visits. It has been noted that patients' adherence improves right before and right after the doctor's visits. Before is because the patient needs the treatment at that time. After is because the patient knows you're going to ask them, how did you use the medication, and did you actually use it? So there is a doctor or a study that was shown that a follow-up visit within 2 weeks can usually help to ensure that the patient is comfortable using a medication. And if the patient comes, alternate treatments can be explored if necessary. Then after that, the follow-up can be as frequent as needed. Another thing that is physician-related, patient education. How many of us take the time to explain to the patient what the disease process is, what medication we're giving them? How many of us are empowering the patient? If we do that, maybe the patient may be more adherent to the medication because they understand what's going on and why they need the medication. So there's also the patient-physician relationship, our doctor interpersonal skills. Do we have the empathy, and are we creating trust between yourself and the patient so that the patient can adhere to the medication depending on how you've related to them? Also, the time spent per patient. Is it like a continuous thing? We just want to clear the queue, or are we taking time with the patient so that the patient can feel like we understand them, we're answering their questions, the patient leaves there feeling comfortable? So this is just a diagram to show everything that I've just said. So what the disease perception, the personal factors, the social, the information, the treatment, and the physician-patient relationship. So what are the methods that are used to measure medication adherence? So one is the patient self-reported measures, whereby you give the patient a questionnaire and they fill it. It's easy, it's cheap. However, there can be a lot of misleading information because the patient can either lie or either overestimate or underestimate. Also, the pharmacy prescription refill records. So usually we check this system is whereby the patient, the pharmacy uses when did they last come for the first dose? When are they coming for the second dose? Is it the appropriate time, or has it taken longer, or has it taken shorter, so that you're able to understand whether the patient is using the medication properly. There's also the medication weights and counting. So that one, for example, is the pill count. So if you've given a patient an OD dose for 30 days, and the patient comes back after 2 weeks with only 2 pills, you see now that's the patient either overdid the medication. If the patient comes back with more medication after the time, that means they were not adherent. So there's also something called medication event monitoring system. So this is an expensive method whereby there is a record electronically when the medication bottle is opened. So every time the medication bottle is opened, a record is set electronically to show that the patient has taken the medication. So it's expensive, and it doesn't really mean that every time the patient opens the medication, they have really taken it. It just means that open the bottle. So you're not sure if it is something that they're actually doing to continue with the records or is something different. So the others are the PASI. psoriasis area and severity index, the treatment satisfaction questionnaire for medication. So the patient fills it himself. So the Spanish have their own, which is the Spanish satisfaction with treatment of psoriasis questionnaire, and of course the DLQI. So how do we improve the treatment adherence in psoriasis patient? So the patient needs to be satisfied. So we educate the patient. One, we manage their cost concerns. We need the patient to understand the dosing regimens. We also address the side effects, and we also treat the concomitant conditions. This is just the same thing, but with more words. So there's also the therapeutic patient education, using diagrams, videos, simplifying the treatment regimens. So either you give a once daily dose, combine the medication and tailor it to the patient's preference and lifestyle. Minimize treatment costs, consider giving generics. Reminder programs, send a text message, an email, or we can also create an app. Early follow-up visits and short-term treatment goals. This is just everything I've said in a summary. So there's also need for us to take our own ways of doing the adherence measurement. So we can design our own as dermatologists in Kenya or dermatologists in East Africa. And those are my references. Thank you.